Good morning. My name is Catherine Hill, and I am a student in the DNP program at the University of Massachusetts Lowell campus. This is my final project for epidemiology and health promotion, and I will be discussing disparities in HPV vaccination in the United States. Throughout the presentation, I chose to use the terminology or the language of the researchers. So I do recognize that many may not identify as women or may refer to themselves with different terminology or language. I also try to include many of the concepts that I've learned in class over the last 12 or 13 weeks. So our goal was to choose a Healthy People 2020 topic and really focus on the impact to public health on this topic. So the overarching goal of Healthy People 2020 is to attain high quality, longer lives, free of preventable disease, disability, injury, and premature death, and achieve health equity, eliminate disparities, and improve health outcomes of all groups. So my topic is on sexually transmitted infections with a focus on HPV and HPV vaccination. And the Healthy People 2020 objective is to reduce the proportion of females with HPV infection, have 80% coverage for all of those females who are part of the population and have the vaccine available to them. And I really also wanted to look at social determinants of health because I'm really interested in disparities in healthcare and access. And so the social determinants explore how programs, practices, and policies in these areas affect the health of individuals, families, and communities. And the five key determinants include economic stability, education, social and community context, health and healthcare, and neighborhood and a built environment. So I really wanted to take a minute to just talk about what human papillomavirus is and what the impact is individually. So human papillomavirus is an etiologic agent for common dermatologic and sexually transmitted infections. It is the most common sexually transmitted infection that we have across the US and the world. And sometimes the immune system can actually cure this infection. The risk of being infected at least once in a lifetime for both men and women is as high as 50%. We do know there are over 100 strains of the virus, and we may find more as more research emerges. But the low-risk strains, type 6 and 11, are considered non-oncogenic, and those are usually responsible for the skin and respiratory infections, so cutaneous warts, anogenital warts, and recurrent respiratory infection called respiratory papillomatosis. Our most concern is the high-risk types, and that includes 16 and 18. We consider those to be the oncogenic types, and that types are most responsible for high-grade cervical dysplasias and invasive carcinomas. So I am a visual person, and so when I saw this on the CDC, the iceberg, it really helped to put this into context for me. So the majority of the cancers on the slide that we see are caused by the high-risk strains of HPV, so 16 and 18. And if you look at the cancers versus the precancers, there are an estimated 33,000 cases per year. And I think what we're most aware of are the cervical cancer at the top, but below the level of the water or the iceberg below, we have a lot of cancers that we're finding are associated with the high-risk strains of HPV. And I don't think there's enough education around the impact of cancer reduction in other areas outside of cervical cancer right now. When you look at the precancer, cervical precancer, there are 196,000 per year in the United States. And really, it's important to know that when we're treating these cervical precancers, we can be impacting the fertility of that woman. So what is the significance of this problem? So HPV is clearly a public health crisis, and HPV vaccination needs to be a public health priority. So compared to other vaccinations, HPV vaccination rate is the lowest among individual or series vaccinations. The study that I have on the slide that's cited to Bednarzik in 2019 in his population actually found that the initial HPV vaccination was 66%, but the completed series was 49%. And then in the same population of his study, the Tdap series was completed at 89% and the meningococcal series at 85%. So why? Why is this vaccination less used than other vaccinations? And really, I think that there are gaps in evidence for how to complete effective and culturally competent education and interventions. And our education should start to focus on the decrease in cancer rates versus that cover all of the cancers versus just the decrease in sexually transmitted infection. Another concern, we know that there are knowledge and attitudes that impact all vaccinations. We have vaccine hesitancy, the anti-vaxxer movement out there. We have religious concerns. People are worried that vaccinations are made with human embryos. We have parental misunderstandings around the HPV vaccination, and many think that if their adolescent receives this, they will become sexually active if they're not already sexually active. And there's really a lack of support to our minority groups. When we think of social determinants of health, the public health issues around this are clearly access. Do we have enough transportation to healthcare visits or clinics? Are there enough providers to work with minority populations, especially in rural areas? How do we get those that are 400 or 500 miles from a provider to be able to complete any vaccination series? There's a cost. In Massachusetts, vaccinations are free if you're under the age of 19, but once you hit the age of 19, there's a cost associated with them. And if you're uninsured, many cannot afford that cost. We also have to think about implicit bias and racism, systemic racism, and we all know that outcomes are better when your provider looks like you look. So we have a lot of barriers that we need to address. So I thought I was picking a pretty narrow topic, and what I learned as I started to look at the research is I actually picked a really big topic, because thinking of knowledge and disparities around HPV vaccination, there are so many groups out there that fit the minority or category or where disparities lie. I just didn't know how to wade through all that literature. So what I tried to do is pick some of the key articles to talk about here. I have two that I've critiqued, and then you can see the remainder of the articles that I read in the reference list. So I'm just going to briefly go over these. These are not my critique articles. It's just a brief literature review. So Agenor et al. In 2018, this study really focused on the social determinants of health and looked at racial and ethnic disparities between minority populations and for those who were born in the US and those who were not. It's a population-based study. There were over 15,000 women who were the subjects. There was no intervention. It was an observational study, and they used the data from the National Health Interview Survey. I will be talking a little more about that in one of the studies I critique. For any of you who have been in biostatistics, we use that data throughout that course. They did a multivariable logistic regression. Logistic regression is a mathematical model that's used in statistics to estimate the probability of an event occurring given some previous data. I'm not going to spend a lot of time on analysis, but just because I'm using the word, I wanted to define it a little bit. So this study actually found that those missing the initiation of the HPV vaccine were less likely to be born in the US, were less likely to have a college education, less likely to be insured, and less likely to have a PCP. And all of those were found to be statistically significant. So with a p-value of less than, we know, 0.05, that data is statistically significant to us. The Apaden study for 2018, the second one on the screen, they looked to examine health disparities in HPV vaccinations among sexual and gender minorities. They had 15 self-identified subjects between the ages of 23 and 26 years. I really, really like this study, and mostly because it was done in Boston, and I'm really interested in the SGM population. So there was no intervention. They used focus groups, discussions, and interviews. They did have a descriptive analysis of the subjects, but they used a coded thematic analysis. So this is really a qualitative study. And I'm really learning to like qualitative data. I'm working with it a little bit at work, and really thematic analysis is fun. They did find that there were several levels that impacted HPV barriers to vaccinations, and there were patient, provider, and systems. What they found, and I just really want to talk a little bit about the provider, was that that there was a cultural competence issue that really surrounded SGM affirming healthcare settings. So this population didn't feel comfortable just talking about their sexual needs or their sexual health with any provider. The third study is Beechler et al. In 2017. This is the only study that's actually a true intervention study. So it's experimental, and they looked at the efficacy of the HPV 16 and 18 vaccine against various cancers. The intervention was either they were randomized to either receive the HPV vaccine or receive the hepatitis B vaccine. So each group got a vaccine, but not the HPV vaccine. And for 4 years, they followed up the population with interviews, pelvic exams, and cytology screening. The analysis was computing a one-time detection for any type of cancer. And what they did find was a statistically significant difference in the intervention group compared to the control group. So those that received the vaccine actually had a statistically significant lower risk of cancer than those that received the hepatitis B vaccine. The Boyaki article from 2017 assessed racial, ethnic, and gender disparities in HPV vaccine and knowledge. So I pulled this article because I really wanted to think about knowledge and disparities with knowledge. It was an observational study. There was no intervention. They also used the Health Information National Trends Survey from the CDC, and they looked at over 6,000 adults over the age of 18. And what they found were that disparities existed in knowledge. And when they compared gender, men had a knowledge of 57% that was accurate compared to women that was 74% that was accurate. So women had more accurate knowledge than men. And when you compared race and ethnicity, Blacks and Hispanics had lower knowledge than the white population did. And all of those were also statistically significant. So the next to last study is the Escoffery et al. In 2019. And this was a multi-level interventional study. It's actually a mixed methods where they were looking at adolescent uptake of HPV vaccination, but they were focusing on federally qualified health centers. And what they did was they offered 3 different types of intervention, and one was $90,000, the second was $10,000, and the third was education only. And they needed to use that money to develop education and resources for both the adolescent population and the staff. They then did in-depth interviews. They had 32 people that they were interviewing at various sites, and they reviewed and coded the transcripts independently. And then they identified successors and barriers. So what they found for successors was the electronic medical record was helpful, support staff and teamwork, concrete educational tools and resources, and having provider champions on site who are always thinking and looking at ways to get that HPV vaccine on board. They found, again, the electronic medical record not only to be a successor, but a barrier because it wasn't always working correctly or HPV vaccines weren't always entered correctly. They had a lack of time for training, competing priorities, staff buy-in, and parental hesitancy. So as providers, we're just not allowed the time to really sit down and talk about the impact of HPV vaccination. And then the last study is Thomas et al. In 2019. This was a convenient sample from a college that was really a college with the majority of population that are minorities, so Hispanic and African American. It was an observational study with no intervention. They did have the students complete the 3 surveys that you can see under the methods section there. They took about 45 minutes to do the survey, and then they used the SPSS software to analyze the data Again, those of you who took biostats already, we have used that software. And what they found was that females were 1.68 times more likely than males to receive the vaccination. Hispanic students were 1.5 times more likely to receive the vaccination than African American students. And those who actually used condoms or stated they used condoms at least some of the time were 0.67 times more likely to use or to have the hepatitis B vaccination than those who did not use condoms routinely. So after going through the literature, I chose 2 articles to critique. The first one is on uptake of the vaccine and its prophylactic vaccination against human papillomaviruses to prevent cervical cancer and its precursors. So this design was a meta-analysis of phase 2 and 3 randomized controlled trials. It's actually the highest level of evidence that we have in most literature scoring systems or tools. And they wanted to look at the harms and protections of prophylactic HPV vaccination. I learned pretty quickly that critiquing a meta-analysis is really difficult. They are long studies and there are a lot of information in them. So this review addressed 3 different prophylactic HPV vaccinations to be included. There was a monovalent one, a quadrivalent, and a bivalent one. And they were actually looking for all female subjects of all ages, but then they broke them out into never having HPV in the past, having some HPV infection in the past, but mostly low risk, and then those that may have had a high risk HPV. And they were looking for outcomes of high-grade intraepithelial neoplasias, invasive cervical cancers, and the safety of vaccinations. So I thought it was important to show the PRISMA table on the right, and I did take this right from the article. And any systematic review really has a requirement is that you have a PRISMA table. So you can show the articles you started with and how you were able to eliminate articles to come down to those that were included in your review. So these authors used Cochrane database, Medline, MBase, and other international registries to search for articles that included HPV vaccination with their subjects that we talked about earlier. They came up with 1,685 articles. They were able to add a few more based on additional research they knew about. So they started with 1,797 articles, removed the duplicates, and then individually they screened the 1,763 articles together. And I mean, so they did it individually, and then they were able to eliminate 1,617 more. And then together they screened the 146 articles to really eliminate discrepancies, and they excluded 90 more. So they started with 1,797, and how they ended with the systematic review had 56 trials, and the meta-analysis had 26 trials. And there were a total number of participants in all of those combined trials that were over 73,000. So in this study, the measure of treatment that they were looking at was a computed risk ratio from the rates of events among subjects receiving vaccinations to those receiving a placebo. And the dependent variable was HPV vaccination. The independent variables that may have impacted those outcomes were age, HPV baseline, infection status. So the results of this critique were that there was a high certainty of evidence that HPV vaccination prevents cervical cancer in adolescent girls and young women ages 15 to 26. This is the results of the meta-analysis. The systematic review actually created extensive review tables similar to the literature review that I showed on an earlier slide. So if you're interested in this data, it's great to pull the Cochrane review and go through it. They found that the effect was greater in those who started at a negative for high-risk HPV prior to the intervention. So if women had high-risk HPV already, the effect was not as good in them. So this clearly shows our need to get HPV vaccination started at a very young age in these adolescents. The adverse effects were the same between the control and the intervention groups. So these included local site reactions, mild systemic effects, adverse pregnancy outcomes, and unfortunately death. The overall number of participants in the study that died was very low. They were equal in both groups, those that received the HPV vaccination compared to those that received the placebo. They couldn't find any pattern or cause for the timing of death, except that it was higher in the participants as they aged. So this may not be a safe vaccine to continue to do research on for older populations. So the strengths and limitations of this, again, it's the highest level of evidence that we have out there in most of our literature scoring tables. The data extraction really created a summary of findings from those tables that can be translated into the clinical setting. Funding was only found in one of the studies that was included in the analysis, and I know that we can sometimes have biases around studies that have funding support from vaccine manufacturers. So that's a strength that there was only one. And they felt like there was an overall risk of bias when they assessed the entire study using the Cochrane's risk of bias tool. So they felt like their recommendations were strong. Limitations to the study, it was not large enough from a sample size, they felt, to evaluate the cervical cancer outcome, and they included studies in which only one immunization was given. So rather than look at completing the entire series and being able to compare it to those who had none, 1, 2, or 3, it really failed to highlight what the higher degree of protection that could come from completing the entire series. The second study that I wanted to critique was race, nativity, and sex disparities in human papillomavirus vaccination among young adults in the US. So this really helps look at disparities that we have and will help us think about those social determinants of health to really engage these populations better. So they were looking at racial and ethnic disparities for vaccination initiation. They were looking at examining the nativity, which is birth, on vaccination status. So were you born in the United States or not? And then they also wanted to investigate sex differences. So it's a cross-sectional study design, which is observational. And they started with the National Health Interview Survey from 2014. And that is a survey that's done every year from the CDC, and it gives us information for health on civilian non-institutionalized populations in the United States. And it's one of the major programs that researchers use to look at data. But they felt when they looked at this that they may not have a good sample from the Native Hawaiian and Pacific Islander population, because if you look at the sample on the slide, the majority of those from that survey in 2014, the 36,000 plus, did not include an identification for the Native Hawaiian and Pacific Islander population. They may have fell in the other for 62, but they weren't sure. And that's why they added in the Native Hawaiian Pacific Islander National Health Interview Survey to this data, which increased that number to 2,500 more in the sample size. So adults were 16 to 26 years of age, and they were able to combine the two surveys to allow the researchers to have a better understanding of more minority groups. So for this one, for the measures, they were looking at the survey data, and the question that was being answered in the survey data was, have you ever received an HPV shot or a vaccine? HPV stands for human papillomavirus. The vaccines are sometimes called Cervarix or Gardasil. And so the responses that they could answer were yes or no. And that makes this a dichotomous dependent variable. The independent variables were sex, race, ethnicity, and age. But some people refused to answer it. The data was not ascertained, or they could say they don't know. And those were coded as missing data. So there was a significant number of subjects that did not actually answer the question or were coded as missing. What the results showed from this second critique was that at least 1/4 of the adults received HPV vaccination at least once. So that's actually very low. And remember, we're looking at minority populations when possible. Women actually have a higher rate of initiation of vaccination at 41% compared to 10% for men, which is statistically significant. And when you look at minority populations, Asian women had the lowest vaccination initiation and white women had the highest. But they were able to get that Native Hawaiian and Pacific Islander data in there too. When they looked at vaccination based on nativity, so those born in the US had a higher initiation rate compared to those who were not born in the US. And when they looked at gender, they found no significant racial ethnic differences detected between men. And that's men across the genders. So Asian men, Hispanic men, Black men. There was no statistical significant difference among groups of men. So when we think about strengths and limitations of this study, so it did address previous research gaps because there seemed to be a gap in comparing all of the minority populations in the United States from race and ethnicity. It identified that vaccinations for HPV are low across all adults in the United States, regardless of race and ethnicity. It did identify the impact of nativity. So I think as providers, we need to think about those patients that we work with who maybe are not born in the United States and maybe evaluate more what their hesitancy to vaccination or social determinants are. It used existing data sets, so there was no need to do more data or surveys. And they did use a method to try to reduce biases because when you combine data sets, there can be an issue with bias that can happen. And so they used sampling weights and the steps that were delineated by Kaminska and Lin, which actually made for a stronger data set to use. The limitations that we needed to think about in her were non-response bias. So remember I said that some data was coded as missing or not answered. So we did not have everybody answer this question for us. It's self-report on vaccination, and sometimes I can sit down and say I'm not sure which vaccinations I've had. And so I think that recall bias is an issue because did people who answered yes really receive at least one dose, or did those who answered no not receive it? One of the other concerns is that they really did not look at other factors like cultural, sexual orientation, or social determinants of health, which could have given us really more data on how to work with minority populations. And they also did not address the adolescent population in this study. So when I thought about research gaps for disparities, I really felt like as I went through the literature, there was a lack of studies on unique populations really specific to the LGBTQ plus groups. They did have limited data on lesbian women and transgender female to male, but most of those were case studies or descriptive data. So we really need to increase the quality of the studies that we're using on this group. So is there the opportunity to increase HPV vaccination rates during acute care and follow-up visits? And I did not find studies on that. Think of as providers, we really see 3 or 4 patients an hour sometimes if we're doing acute visits, and that barely gives us time to address the acute issue. So that really eliminates the opportunity for primary prevention. And so is there opportunity to look at those visits a little bit differently and use our support staff or have champions in the office to help us identify where there are gaps in vaccinations? Will there ever be HPV screening for men to improve vaccination rates? Unfortunately, when this vaccine came out, it was really focused on women. And so men were excluded in the initial studies, and they're still excluded from a lot of the studies that I see. And so would screening these potential HPV high-risk strains for men somehow improve the vaccination rates in that population? We learned about the media and social media in class. I have a few studies in the reference page on the impact of social media on HPV vaccinations. Would there be a way to use social media messages to especially the adolescent population? They are the experts in social media, and would that increase vaccinations? I'm a little torn on the age for administration. We know that the FDA has this approved up through the age of 26, and then on a case-by-case basis up through the age of 47. The concern is that with that one meta-analysis that showed death rates slightly higher as you aged, that would really need to focus on the reasons that we might want to vaccinate those over the age of 26 and get more concrete information on that. And then obviously vaccine duration. As we're finding new strains of HPV vaccine, do we need to add another vaccination in? Will we need boosters as we get more data? So when we think of the implications for population health, we need to develop successful strategies for education and uptake for HPV vaccinations. We really have the opportunity to prevent increased morbidity and mortality associated with these high-risk HPV cancers in both men and women and across all age groups if we can really increase the uptake for at least one, if not the full series of the vaccination. We can really prevent the increased healthcare burden that's used in treating even the low-risk HPV cancers, where we're doing a lot of intervention to young women, but the cost to treating cancer for high-risk strains of HPV can really decrease the healthcare burden if we can impact that. And we really need to think about decreasing the stigma associated with sexually transmitted infections. Unfortunately, that stigma still persists. We find people who are embarrassed and don't want to talk about it. And I think, again, if we really focus on using the HPV vaccination as a cancer prevention strategy versus a sexually transmitted infection prevention strategy, we may be able to get over that barrier. So when I thought of recommendations for the future, we should advocate, dispel, respond, learn, ensure, and encourage. So we need to advocate for funding at the federal and state levels to reduce the impact of the social determinants of health on vaccine uptake. I shared several studies through the literature review and then one critique on the impact of minority populations. We need to dispel myths about vaccinations that are communicated through our social media sites and the vaccine hesitancy and anti-vaxxers that use social media to get at, especially the younger generation. Somehow we need to stop that. We need to respond to parental concerns about HPV vaccinations with standardized, consistent language. We all need to use the same message and say the same thing because it's really fear. It's fear from parents and it's fear from adolescents. We need to learn from states with the highest HPV vaccination rates and apply best practices to other states. Who's got it right? Who's doing it well? And what can we share? We need to ensure that providers have enough time during all points of contact, including acute care visits, to look at primary prevention for HPV. And it's helpful, I think, to encourage graduate students to focus on their projects around HPV vaccination, whether it's DNP programs or PhD programs. There are so many opportunities where research can be done. So that is the end of my presentation. Thank you for listening. I hope you enjoyed it, and I hope I was able to give you a good basis for the population impact to lack of HPV vaccination. I am just going to scroll through the reference page here so that you can see the many references that I did use in this presentation. If they're not cited in the presentation, I actually did read through all of these articles. So thank you all. Have a great weekend, and I thoroughly enjoyed this class and learning with all of you.